diabetes mellitus and extraction. Mainly why it is important to study or to give importance about diabetes when we are doing a minor surgical procedure, because there are some complication associated with diabetic patient. So firstly, today we will know about diabetes, then there how to confirm a patient has diabetes, then their oral manifestation, and lastly how we will manage if a patient come with some tooth that need to be extract or other minor surgical procedure. So firstly, diabetes can be physiological and pathological. The physiological diabetes mellitus usually occur during pregnancy, that we call gestational diabetes mellitus, and pathological is associated with blood glucose level, and another is diabetes insipidus, that is related with decreased serum antidiuretic hormone. So diabetes mellitus associated with blood glucose is two types again. One is insulin dependent, that is type 1, which usually the onset is usually in early stage, and another is non-insulin dependent, that is there is insulin resistant but insulin is present. This, and in case of type 1 the insulin is not present. So in type 2 is late onset usually. So how will we know that a patient have diabetes mellitus? There are mainly 3-4 symptoms that are very common. That is, the patient complain of polyuria, frequent urination, polydipsia, and that is and polyphagia. Okay, so the patient has difficulty in the patient feel frequent thirst and frequent hunger, and okay, so there are mainly there are some investigation we can do to confirm fasting blood glucose level. If the fasting blood glucose level is greater than 7 millimole per liter, and then if the blood glucose level 2 hours after breakfast is 11 millimole per liter, then we can do HbA1c. Another test, HbA1c, which is greater than 6.5%. So then we'll consider it as diabetic. So if a patient has these sign symptoms and patient has one test positive, then we can consider him diabetic. If no sign symptom present, but among this the 2 test is positive, then we can consider also diabetes mellitus. If the patient has no sign symptom but one test is positive, then we can give him OGTT, that is oral glucose tolerance test. Will give patient 75 milligram of glucose dissolved in 30 ml of water, and check the blood glucose after 2 hours. If it is 11.1 millimole per liter, then we can consider he may have diabetes. And if it comes within 140 to 199 milligram per deciliter, then we called it impaired glucose tolerance test. And another one is HbA1c, that is HbA is adult hemoglobin, and C here is carbohydrate, 1 is 1. So hemoglobin has globin chain. If globin chain has glycine amino acid, and with this glycine amino acid the carbohydrate molecules are get attached, so then we call it HbA1c. If among 100 hemoglobin A 6 up to 6 hemoglobin A uh, can remain attached with carbohydrate. If it is more than 7%, then it may consider as diabetes mellitus. So HbA1c, it will give the reflection of diabetes for 3 months, because the lifespan of RBC is 120 days. And now some oral manifestation. So some oral manifestation of diabetes mellitus. So first there will be there is periodontitis, which is very common in case of diabetes patient. In periodontitis, we usually see the apical migration of junctional apical migration of the epithelium with pocket, can be suprabony, infrabony pocket, and alveolar bone destruction is also seen. So there will be mobility. So mobility and periodontal pocket, these are found in periodontitis, and it is a very common complication associated with diabetes mellitus. And in diabetes patient, various type of fungal infection is also seen, like the pseudomembranous candidosis, the white patches. Okay. And or there can be retinomatous candidosis. Here the portion seems red and can have angular cheilitis. This kind of denture-induced stomatitis. These things are very common. These things are common and can occur in case of diabetes patient. And another one can be occur if the patient is on metformin. Then metformin and other oral hypoglycemic drug can cause a lichen planus-like lesion, which is usually a lichenoid reaction. So another one can be fissure tongue. So fissure tongue can be due to gestomia also. In case of diabetes patient, there is some problem associated with salivary glands. So salivary flow is decreased, and this give rise to different complications. So let's see some others. So in case of in diabetes patient, there is alteration in the basement membrane of salivary gland. So the salivary dysfunction will occur and decrease the salivary flow. So there is dry mouth, and it is also said that due to polyuria, the dry mouth can also occur due to dehydration maybe. And within saliva there is immunoglobulin A, and if the salivary flow is decreased and amount of immunoglobulin A is decreased, and immunoglobulin A is bactericidal, which protect from caries, prevent proliferation of streptococci and other bacteria, and does it protect from caries. So if the salivary flow is decreased and gestomia occur, then the opposite will happen. The immunoglobulin A portion will decrease, and there will be proliferation of bacteria and less protection against caries. And also due to the decreased salivary flow, the buffering capacity of the saliva decrease, so the pH decrease, and in low pH the enamel dissolution, and ultimately the caries occur. So we have also we already talked about periodontal disease. But why this periodontal disease occur? Because in case of diabetes patient, two things we see. Number one is neutrophil dysfunction. Why this neutrophil dysfunction? Normally in case of when there is a foreign body outside a blood vessel. So if it is a blood vessel and it's a neutrophil, if we see, then if there is a foreign body, say this is a foreign body outside, so what will happen? There is some adhesion molecule, that is p-secretin, adhesion molecule p-secretin, and integrin, which helps in attachment of this neutrophil, attachment of this neutrophil to the blood vessel wall. So when there is deficiency of p secretin and integrin, this will the neutrophil will not attach with the blood vessel wall, and it will not, the diabetes will not occur, the chemotaxis will not occur, and ultimately the phagocytosis will not occur. So due to neutrophil dysfunction, the infection level increase, and resistance against infection and microbial flora decrease. And another thing is collagen fiber, or the collagen fiber formation, collagen fiber metabolism, and that is the synthesis of collagen fiber is decreased. And we know the periodontal fiber is made of collagen. So these things contribute in together in periodontal disease. We have already talked about oral infection, candidiasis, stomatitis, and also there is median rhomboid glossitis, and talked about already denture-induced stomatitis, candida infection, and angular cheilitis, etc. This oral candidiasis can occur. And also there can be burning mouth neuropathic. Burning mouth syndrome can also be seen in case of diabetic patient. Other than that, taste dysfunction, oral mucosa alteration, and poor wound healing. The wound healing usually has 3 stages, that is inflammatory state, then in inflammatory stage the neutrophil act, in proliferative state the collagen fiber proliferation occur, and there is remodeling phase. So the first 2 phase, inflammatory phase and proliferative phase, is affected in case of diabetes mellitus. So there will be poor wound healing. So till now we understand the key factor, that is in diabetes, reduced neutrophil count, increased risks of infection, reduced neutrophil function and increased risks of infection, and impaired collagen synthesis and angiogenesis. So these 2 things mainly we are concerned about. So if a diabetes patient, suppose if a diabetes patient come for extraction, then how will we proceed, or how will we manage? First of all, we'll take medical history of the patient. So we'll ask about when this diabetes occurred to him or her, and the type of diabetes matters. Is it type 1 or type 2? Then we'll ask about his glycemic control, and when the last time he has done his blood glucose test. Then we'll ask about the medication, if he is taking metformin or other hypoglycemic drug or insulin. And we already discussed about metformin, which causes lichenoid reaction, and if the patient is on insulin, then it may he has increased risks of hypoglycemic coma. And we can ask about patient hypoglycemia history, if someday he became unconscious or felt dizziness due to hypoglycemia, or any history of attack of hypoglycemia. That may help for our chairside safety. And we'll ask about associated diabetic complication, hypertension, cardiovascular disease, and diabetic nephropathy, neuropathy, or retinopathy. So there is a form. We can use this form for diabetes patient. That is, first ask about the type of diabetes. Suppose the patient has type 2 diabetes, then the fasting blood sugar, suppose she has done fasting blood sugar 7 days ago, maybe right date and then note the blood glucose level, suppose 11 ml per liter, HbA1c like that. So mention the date when he has done it, and then ask about diabetic complication or other associated comorbidity. If the patient has, then just noted it. Okay, then after that we'll if the patient has not done we'll give some investigation. We can give random blood sugar, fasting blood sugar, and HbA1c. If the patient has uncontrolled diabetes mellitus, then we have to refer treat. If the patient has uncontrolled diabetes mellitus, then and the patient has, then we'll treat the infection. And suppose the patient has come with 15 millimole per liter is fasting blood sugar, and he has abscess and mobile tooth. So what we will do, we'll first treat the infection. We can drain the abscess. We'll give antibiotic. We'll just drain the abscess, give antibiotic, analgesic, and mouthwash. And we'll first control the infection. Then we'll go for definitive treatment. First, active control of active infection is our goal. Then the time, then comes antibiotic prophylaxis. If you are deciding to extract the tooth, if the patient has well controlled diabetes mellitus, then we don't need any antibiotic prophylaxis. But if the patient has uncontrolled diabetes mellitus and the patient is immunocompromised, then antibiotic prophylaxis is needed. And for antibiotic prophylaxis, we can give amoxicillin 2 gram 1 hour before procedure. And if there is if the patient is allergic to penicillin, then we can give him clindamycin 600 milligram 1 hour before the procedure. And if the infection present, we can also start the antibiotic 24 hours before the extraction. So then the timing of the patient, it is better to give morning appointment. So early morning appointment should be given to the patient. The length of the treatment should not be very long. So it should be we have to avoid lengthy procedure. And patient the anxiety control should be done. No stressful procedure. So if the patient is more anxious, then we can give him anxiolytic. Suppose midazolam we can give him, and we can also other stress management protocol, like explaining the procedure, then arranging some music, and asking about patient fear and consultation. These things can reduce patient anxiety. Then intraoperative, then regarding anesthesia, the adrenaline we use with lidocaine does not have significant effect on blood glucose level. But if the patient has comorbidity, like the patient has associated hypertension, then the adrenaline should be limited to 0.04 milligram. Should be limited to 0.04 milligram. Should not be more than that. And the surgical technique should be as atraumatic as possible to preserve the bone and soft tissue, and it will also enhance the healing. Then the antibiotic prophylaxis we have already discussed. And now comes the postoperative management. will give the painkiller, but paracetamol can be given, or ibuprofen. But if the patient is on the patient is taking sulfonylurea, then it is better. Sulfonylurea, that means glimepiride, or this drug here. Yeah, this sulfonylurea drug list is here. So we have to avoid NSAID and aspirins other than paracetamol, ibuprofen, if the patient is on sulfonylurea, because it enhances the risk of hypoglycemia. So in second generation there is glimepiride, glipizide, and glyburide, and in first generation there is tolbutamide. So these things can be issue. And now diet and medication. If the patient, for example, on the day of surgery, if the patient cannot eat before the procedure, or after the procedure the patient may have difficulty in eating, so it is better, if the patient cannot eat properly, it is better to avoid the oral hypoglycemic drug on that day. And we have to give patient follow-up. It is better to give follow-up 14 to 48 hours after, and also after 1 week, to see the healing of the patient and other things. We can give chlorhexidine 0.2% mouthwash, which is antibacterial. What are the possible complications can occur in patient with diabetes mellitus? Usually in patient with diabetes mellitus, the healing process is delayed, and we have already discussed why there is delayed healing. So due to impaired neutrophil function and the impaired collagen formation, this delay the healing procedure. Then there is increased chance of postoperative infection. Even osteomyelitis can occur in patient with diabetes. There is higher risk of dry socket. Yeah. And so if in some case, if the patient comes and the fasting blood sugar level is very high, that is fasting blood sugar level is greater than 10 millimole per liter, and random blood sugar is greater than 14 millimole per liter, then the elective extraction should be postponed, and consultation can be done with patient physician, and necessary arrangement to reduce the blood glucose level can be taken, and then the extraction can be done. If emergency like abscess, first the infection should be drained, antibiotics should be started, and proceed only when the sugar level is stabilized. Okay. And before the extraction, before starting extraction, we must have to confirm that the patient has taken his meal and medication. Yeah. And in our dental chamber, ready glucose source should be available, like juice, sugar packet, in case of emergency. So in patient with diabetes, there is a risk of hypoglycemia. Glycemia may occur. So how we will understand? The patient may sweat, and confusion may arise. The patient skin may be cold, hypothermia may develop, and these things the patient sometimes understand it and